Good morning. It's my privilege and an honor to represent my collaborators and co-author to give you this data on the safety and efficacy of nipocalimab during the Vivacity open label extension phase. Here are my disclosures. So to give you a review, the Vivacity study looked at nipocalimab, which is a anti-FcRn monoclonal antibody that decreased circulating IgG without causing broad immunosuppression. This study was done and showed that at endpoint there was a 4.7 points reduction in MG-ADL versus 3.25 in the placebo group, and the difference was statistically significant. As a result, the US FDA gave this drug an indication in April of this year, and subsequently other countries have also given it indication for treatment of generalized myasthenia gravis. So here is the basic design. Patients who were eligible for this study resemble pretty much all the populations in all the phase 3 study out there. They must be adults greater than 18 years of age. They must have MGFA class 2 to 4, and despite concomitant treatment, they must remain symptomatic, as shown by the MG-ADL 6 or more points. They were then randomized 1-to-1 to placebo or nipocalimab, and at the end of the randomized control period, they were given the opportunity to transition into the open label portion of the study, which is still ongoing. So at the moment, we're going to look at the mean change from double-blind baseline to the open label at week 60. And we look at MG-ADL total score, QMG total score, IgG level, and the response in patients who were able to decrease or discontinue steroid during the open label period. And of course, the main purpose of doing open label is to look at safety and tolerability as well. So here is the open label schema. You can see that it's pretty standard. And what I want you to point out here is that so far, when we did this analysis, 63 of the 76 patients had completed the placebo-controlled period. But you notice here 66 enter the open label. The difference here is that if you had a relapse or exacerbation during the randomized control period, you go directly into the open label. So far we have no one completed the open label just yet. So this basically is our interim data. Baseline characteristics, pretty similar to everything, all the other trials out there. There's a preponderance of women in these studies. Black Americans and Native Americans remain underrepresented in these studies. The mean MG-ADL was 9, and the mean QMG total score was 16. And that's in line with all the studies out there. So if you look at all the studies, the average MG-ADL is between 8 and 10, and the QMG is about 14 to 17. There was roughly 90 years of patients' exposure during the open label. And this slide summarized the change in MG-ADL. So once you start treatment with either placebo or drug, you can see that both groups improve rapidly, but the nipocalimab group responded better, and at the end of the randomized control period, there was a statistically significant difference. Once the placebo-treated patient transitioned to nipocalimab, they also improved rapidly, matching the response seen by a patient who was previously treated with nipocalimab. And at the end of the 60 weeks of the open label, both groups achieved between 5 and 6 points improvement from baseline. That pattern was mirrored with the QMG score. Again, once the placebo patient received nipocalimab, they improved considerably, matching the response seen by the nipocalimab group. And again, by week 60, both groups had roughly between 5 and 6 points improvement from baseline in the QMG total score. As the mechanism of the drug is to reduce IgG level, we see a steady, a very rapid reduction in IgG level that was maintained throughout the randomized control period and the open label. And at the end of the observational period here, we see a 62% reduction in total IgG in both groups. After the randomized control period, this is not a protocol-driven measure, but the treating PI can, at his or her discretion, reduce or discontinue steroid. And in this study, the 45% of the patients had the steroid dose changes, and you can see that at 60 weeks, the mean dose of steroid go from 23 to 10 milliequivalent per day. And despite the change in the steroid dosing, the efficacy remains in these patients, and you can see that here, in the patient who was treated with placebo that transition, they had a 5.5 point reduction, and patient who were treated with nipocalimab all along had a 7+ point reduction. In the QMG scores, both groups got roughly a 7-point improvement. We did not see any new or unexpected adverse events, and the events were similar across both groups. There were 3 deaths in the open label portion. 2 of them were from cardiac event, neither of which was considered related to treatment. 1 death was due to lymphohistiocytosis, and that was deemed by the treating PI to be related to treatment. And of note, the patient was on tacrolimus and other immunosuppressants since about 2015. In terms of lipid level and albumin, the drug caused roughly a 12% increase in both HDL and LDL. As a result, the ratio between the total cholesterol and HDL remained stable throughout the study, and less than 4, suggesting that there's no expected increase cardiac or cardiovascular complications. No patient albumin level reached below the lower limit of normal, and nobody got hypoalbuminemia despite continuous treatment. So in conclusion, nipocalimab treatment resulted in sustained clinically meaningful disease control over an 84 weeks period across both the randomized control period and also the open label in antibody positive adults with GMG. 45% of the patients received corticosteroid, was able to reduce or discontinue the treatment while preserving the efficacy. The mean total cholesterol ADL ratio remained less than 4 and comparable to the placebo group throughout 84 weeks. And at this level, we don't expect cardiovascular complications. There were no new safety concerns despite continuous IgG lowering, and event rates were comparable to the double-blind placebo-controlled period in all nipocalimab-treated patients. Thank you very much for your attention. Yes, I'm trying to get out of here so the next person can.
Thank you, Dr. Vu. I am starting at 10 o'clock per the schedule, so I know we started a little bit earlier, so I apologize for that confusion. But let me just pull this up one moment. Excellent. So thank you all for inviting me to present on behalf of the study team in Amgen, the phase 3 myasthenia gravis inhibition trial, specifically looking at the efficacy of the acetylcholine receptor antibody-positive generalized myasthenia gravis subpopulation through week 52. So these are my disclosures as well as disclosures of our co-authors here. I just wanted to point out that this study was funded by Amgen. And just to sort of level set, so myasthenia gravis, as all of you know in this room, results in fluctuating muscle weakness. The pathogenesis of myasthenia is in fact driven by CD19 positive B cells that really produce the autoantibodies that target the neuromuscular junction, specifically proteins such as the acetylcholine receptor and muscle-specific kinase. So what is inebilizumab? Inebilizumab is a humanized monoclonal antibody that targets specifically CD19, which is expressed on certain population of B cells. And it's those particular B cells that produce autoantibodies that we're most interested in. CD19 expression is present on B cells that produce autoantibodies or antibody-secreting cells, specifically plasmablasts and certain long-lived plasma cells. So in the phase 3 MINT study, we demonstrated a statistically significant change in the MG-ADL score from baseline to week 26 in the combined population of individuals with acetylcholine receptor antibody positive or muscle-specific kinase antibody positive generalized myasthenia gravis. So our objective here is to assess the long-term efficacy and durability of inebilizumab in patients with acetylcholine receptor antibody positive generalized myasthenia gravis through a 52-week randomized controlled trial period. So just to kind of give a study design overview. So this was a one-to-one placebo to treatment arm design that enrolled both patients with either AChR or MuSK antibody positive disease. The RCP was 52 weeks for the MuSK subpopulation, but it actually was 52 weeks for the acetylcholine receptor antibody population. The reason why we had a longer RCP for the AChR is there was a feeling that there might be a delay to clinical benefit in the AChR antibodies population. So we wanted to understand and not switch too quickly to the possibility of open label extension, the benefit of inebilizumab in a 52-week RCP period. So we'll be presenting those data here. So some key eligibility criteria, I already mentioned the autoantibody subtype. These were patients that had to have active generalized myasthenia gravis with an MGFA class between 2 and 4. The minimum MG-ADL score requirement was 6 or higher. Minimum QMG score requirement was 11 or higher. And patients had some restrictions on other immunosuppressive therapies that they were able to be enrolled on. So biologics were not allowed, for instance, and there was an upper limit on corticosteroid or specifically prednisone dose. One of the key design attributes here of this study is that at week 4, all patients were required in a protocol-specified manner to reduce their corticosteroid dose. So by week 24, patients should have achieved a prednisone dose of 5 milligrams per day or less. So what did we see in the 52-week follow-up period? So we are observing continued clinical benefit as measured by the MG-ADL score. So we're seeing in the placebo group a 1.9 score reduction in MG-ADL score versus 4.7. The mean adjusted difference here is 2.8 points between the two groups. The model adjusted difference accounts for some baseline features, including the baseline MG-ADL score, baseline QMG score, for instance, and also baseline corticosteroid dose. So you can see that over time, if you look, in the gray is the initial 26-week period or the primary readout at week 26. So we are observing continued clinical benefit over time. And although it's difficult to make too much out of it, but it appears that patients are doing a bit better at week 52 as compared to week 26 here, just by looking at the raw numbers. Similar observation is made with the QMG. There's a continued improvement at week 52. In the placebo group, we're observing a 1.4 score reduction versus 5.8 with a model-adjusted difference of 4.3. And again, kind of the similar situation where there is a continued clinical benefit that is demonstrated between week 26 and week 52 in the ACHR subpopulation. Cutting the data a little bit differently, these are also pre-specified, looking at a 3 or more point improvement in the scores here. So at week 52, we're observing 72% versus 45% achieving that greater than or more 3-point reduction, which is a 27% difference. If you look at week 26, the difference between the two groups is about 19 to 20%. So again, continued benefit. Similarly, at week 52 for the QMG, at a threshold that was pre-specified of 3 or more points, we're observing 69% in the treatment group as compared to 42%, which is a 27% change between the placebo and the treatment arm. If you look at the week 26, which is in the panel on the left side, we're seeing about a 20% difference in those achieving over placebo that 3 or more point change. So in conclusion, we're observing clinically meaningful improvements in both the MG-ADL and QMG scores in patients treated with inebilizumab in the ACHR subpopulation through week 52 after undergoing a protocol-specified steroid taper. The pre-specified analyses here support continued improvement in efficacy of inebilizumab at the 1-year mark, and the findings continue to support the role of anti-CD19 B-cell depletion therapy for generalized myasthenia gravis. I'll just point out a few key things: that inebilizumab, based on its MOA, targets the upstream immunopathogenesis driving the disease and represents a potential novel therapeutic approach for the management of myasthenia gravis. And I'll just leave you that further assessments of safety, analysis of additional endpoints that were pre-specified, such as exacerbation, quality of life, and durability response, are continue to be ongoing. And I'll just share with you that in our open label extension, which we haven't yet fully analyzed, we're presenting some additional data on more long-term follow-up that can go as far out as an additional 3 years. So I'll just leave you with a QR code here that links to our primary manuscript that we published earlier this year for anyone that wants to reference the demographics and any other additional details with regard to the subpopulation. So thank you very much. I know we're taking questions at the end of the session. So that concludes my presentation today, and we'll move on to the next speaker. So I'll introduce and invite to the podium. Let me just look at the session here. So, Dr. Schwade, did I pronounce that correctly? Schwade, I'm sorry, Dr. Schwade. My apologies. I thought I would be introducing Dr. Vu, but he beat me to the podium this morning. So thank you very much.
No, you're good. Thank you so much for allowing me to speak today. I do like when people call me Dr. Schwade because it sounds more formal and fancy, but it is Dr. Schwade. I'm a pediatric neuromuscular specialist at Lurie Children's in Chicago, so I work primarily with Dr. Nancy Kuntz, that I'm sure many of you know. Today I'm going to be going over the ADAPT Junior and ADAPT Junior Plus study that looked at IV efgartigimod in pediatric patients with MG. These are my disclosures. So this study built on previous studies, the ADAPT and ADAPT Plus study that looked at IV efgartigimod in adults with MG. As many of you are aware, pediatric MG is an extremely rare disease. It accounts probably for about 10% of all MG worldwide and has an incidence that's about 1 to 5 per million. So it remains an unmet need, and it remains very difficult to recruit patients for clinical trials. So here, again, we're going to review the phase 2/3 clinical trial that looked at IV efgartigimod in juvenile patients that were acetylcholine receptor positive. So most of you know this, but I'll briefly go over the mechanism of action of efgartigimod. Efgartigimod is an FcRn blocker. By blocking this receptor, it prevents the recycling of IgG antibodies and shuttles them towards lysosomal degradation. Here's the overview of the ADAPT Junior study. So I'll focus first on the left side of the screen, which was the key inclusion criteria. We recruited patients that were 2 to 17. They had to have a confirmed diagnosis of generalized myasthenia gravis. They had to be kind of intermediate severity with class 2 to 4A and have inadequate response to standard of care. Today I'm focusing on the adolescent cohort, so that's the cohort from 12 to 17. And at a later meeting, we'll have more information on the childhood cohort, which we still have ongoing recruitment for. So if you look at the study design, the picture in the middle, there were 2 parts. There was the dose confirmatory part, or part A, that went over 8 weeks, and then the treatment response portion that went over 18 weeks, a total of 26 weeks. So for part A, patients received 1 dose of IV efgartigimod and then were followed for various measures. And this worked off of previous PK and PD data from the ADAPT and ADAPT Plus trials in adults. And then for part B, we were giving a standard dose of IV efgartigimod, so 1 IV dose per week over 4 weeks. And then patients were continued to be followed, and patients did require repeat cycles if they had reemergence of symptoms. Finally, on this slide, you'll see on the right the ADAPT Junior Plus portion of the trial, which is the open label extension, and that's ongoing. Again, continuing to look at efficacy and safety for IV efgartigimod in pediatric patients. So here's the basic demographics. You can see on the top, the N was 11. This is very typical for pediatric MG trials. They're extremely difficult to recruit. You know, I work at Lurie Children's Hospital in the center of Chicago. We have 4 pediatric neuromuscular specialists. Among all of us, we follow about 10 active patients. So very hard to recruit. But in terms of the demographics, majority were around 15 years of age. All were female. Majority were white or not Hispanic. And then if you look at the mean MG-ADL, the mean MG-ADL was around 6. Unlike ADAPT and ADAPT Plus, there was no inclusion criteria for a minimum MG-ADL score, but the mean did fall around 6, which is similar to the adult trial. So here I'm going to focus on part A. Remember, part A is the dose confirmatory portion of the trial. 1 IV dose of efgartigimod, and then following IgG levels and acetylcholine receptor levels over 6 to 8 weeks. And you can see after 1 dose of IV efgartigimod, there's a precipitous drop in both the IgG levels and the acetylcholine receptor levels that then recovers over the next several weeks after that initial dose. Here, focusing on part B, so that's the treatment response portion of the trial. And again, you can see here we're focusing on cycle 1 and cycle 2, as there were patients that required repeated cycles due to reemergence of symptoms of MG. So again, you see 4 doses that are given over the course of 4 weeks. You have that same precipitous drop in both IgG levels and acetylcholine receptor levels that then starts to creep up after the initial 4 doses. And then again, those who required cycle 2, which is a number less than 11, so 5 is the N for cycle 2. Again, I had a drop in the levels of IgG and acetylcholine receptor that then started again to return to baseline after the 4 doses. So here, I'm going to focus on the MG-ADL. Again, this was measured in Part B of the study. And you can see on the left side of the graph, the first cycle, so 4 doses of IV efgartigimod. You have the baseline MG-ADL, and you can see a drop in the MG-ADL that is sustained over the course of those 18 weeks. And for those that required a second cycle, you can see with the second cycle, you again get a pretty significant drop in the MG-ADL, with some patients requiring more cycles with reemergence of symptoms. I want to point out a couple things though, because I know that MSE is a very important, clinical measure that we look at in terms to understand quality of life and how patients are doing. And there were a majority of patients that did reach an MSE with an MG-ADL of 0 to 1. And I'll go over that a little more detail when we think about ADAPT Junior Plus, which is the open label extension study. This is followed now out 9 cycles for the patients that did require repeat cycles. And you can see that repeatably with each cycle, you have a decrease in the MG-ADL. And then turning the graph a little bit to instead focus on the raw MG-ADL data, but rather on MSE, I'll point you first to cycle 3, where you can see that 66.7% of patients in that cycle did reach MSE, so an MG-ADL of 0 to 1. In terms of safety, it was very similar to the ADAPT trial in adults. So most commonly, headaches, oropharyngeal pain. There were no discontinuations in the trial due to side effects from the medication itself. There was one patient who did discontinue due to pregnancy. So in review, again, this is a small study, as all pediatric MG studies are very small, but there remains an unmet need. For patients with pediatric MG, we have very limited available products that are FDA approved, and it can be a very debilitating disease for patients. So I think it's important to look at this study, understand that there was reproducible decrease in the MG-ADL, as well as reproducible decrease in the IgG levels and the acetylcholine receptor levels. And hopefully with more information from the childhood cohort, we'll be able to better understand how we can serve our pediatric population. Thank you so much.
Good morning. Wow, even with all those extra chairs, it's still standing room only. I am honored and excited to present the nipocalimab data in adolescents, especially because it's amazing that there's 2 studies back-to-back for adolescent patients. So we've come a long way in treating our younger patients, and that makes me very excited. So we're going to talk today about the active treatment phase and the long-term extension phase, or Vibrance, the phase 2/3 study. These are my disclosures. So nipocalimab, as you know, is a monoclonal antibody that binds to the FcRn, and it has affinity and specificity for interaction with IgG. And so because blocking FcRn, your IgG can't be recycled and your IgG levels drop. And this is based on a pivotal phase 3 trial, Vivacity, in the adult study, which showed the nipocalimab levels lowered IgG levels and pathogenic IgG autoantibodies. There was improvement in those patients, sustained over 24 weeks and even up to 60 weeks, as you heard a little bit earlier today, in the open label extension. And so these results actually supported the FDA approval of nipocalimab for the treatment of both adult and pediatric patients 12 years and older. So the objectives of this study were to evaluate the effect of nipocalimab on IgG safety, efficacy in adolescents 12 to 18, so also cohort 1. There's a cohort 2 undergoing now for the 2 to 12 year of age patients, and this was for patients who exhibited insufficient clinical response to standard of care. And these data are summarized up to the clinical cutoff of August 23rd, 2024, which was week 72 for some of these patients. So it's a global multi-center trial, phase 2-3, evaluating nipocalimab and standard of care in patients 2 to up to 18 years of age who are antibody positive myasthenia. So they were initially treated with a loading dose of 30 milligrams per kilogram, followed by 15 milligrams per kilogram every 2 weeks during the active treatment phase, and then they switched over to the long-term extension phase, where they were given the 15 milligrams per kilogram every 2 weeks, or they had the option of moving over to the 30 milligrams per kilogram dose every 4 weeks. The primary endpoints, as we talked about, were the total IgG levels, along with safety and efficacy data, and secondary endpoints were the QMG and the MGADL scores. And so the results we'll report today are from the active treatment phase, which was up to week 24, which initially had 7 patients that we presented, but now we had an 8th patient that was included, and we have data now out to 72 weeks for some of those patients. So here's the study design as we talked about. So 9 patients were actually screened, 8 were eligible, and 8 started. 1 actually discontinued because there was no benefit after the active treatment phase. 5 are still ongoing, with 3 of them completed through week 72. And the endpoints which we discussed, and this study is still ongoing. So the patients ranged from 12 to 16 years, more female than male, more Asian patients in the study. I also point out that the baseline MGADL was 3.5, and they were all acetylcholine receptor antibody positive. Their baseline QMGs were 14. And so, as we saw in adults, the nipocalimab treatment caused a rapid and sustained IgG drop in the adolescent patients, so similar to what we found. And the drop was about almost 70%, which is, again, what we see in the adult patients as well. And this was sustained all the way out to week 72. Looking at the MGADL, there was a clinically meaningful reduction in the MGADL score observed by week 4. And that was also maintained through both the active treatment and the long-term extension, and some patients actually reaching MSE. In fact, over 50% of them reached MSE at some point during the trial. The QMG score was also observed to drop by week 4 and was maintained also through the active treatment and LTE phase. It was reduced to 7 by week 4 and maintained at 7 up to week 24. There is actually 1 patient who had worsening of symptoms after the 72 weeks at week 84, required hospitalization, was treated with IVIG and was better within 5 days. Had actually switched over to the 30 per kilo Q4 for 4 weeks, but then went back to the Q15 weeks and is still on therapy now. So it was generally well tolerated across the active treatment and LTE phase. No significant adverse events or adverse events leading to the discontinuation. As I mentioned, one patient did drop out because of no benefit. 1 patient experienced SAE at week 84, which we just talked about. And another patient had influenza at about week 30 and so had to temporarily discontinue treatment, but then restarted afterwards. The most common adverse event was nasopharyngitis, and then COVID-19 was the next most common. So in conclusion, in adolescents with generalized myasthenia, ages 12 to up to 18, nipocalimab demonstrated a rapid, substantial, and sustained reduction in total IgG scores over a 24-week treatment phase and then maintained through week 72 in the long-term extension. Clinically meaningful improvement was seen in both the MGADL and the QMG scores over 24 weeks and through the long-term extension 72 weeks. And it was well tolerated with very favorable safety profile observed throughout the study. And this was actually, Vibrance is the first study to demonstrate efficacy of the FcRn in adolescents with myasthenia, and nipocalimab is the first FcRn blocker approved for treatment in adolescent patients. and addressing a really unmet need that we have for our patients because, as you know, insurance companies won't pay for it unless the FDA approves it. Or at least we can try to get the insurance company to pay for it if the FDA approves it. So thank you. And now I'll introduce Dr. Howard.
Well, let's continue our discussion on FcRNs, and on behalf of the investigating team and our patients, we thank the committee for allowing us to present our data. We're going to talk about efgartigimod in antibody-negative patients. These are my financial disclosures. Predominantly, our patients have antibodies to the acetylcholine receptor, though there are multiple subsets, another percent directed to MuSK protein, an even smaller subset directed to LRP4, and then we have a group of patients in whom commercial assays do not identify a circulating antibody. And these can be of a variety of reasons. The level is too low, the assay just isn't adequate enough to find it. There are other epitopes that are being bound that are not recognized, as we heard from the excellent lecture by Professor Hibbs. And then there are other auto-targets that we can't identify. And so the seronegative patient is a very difficult population for we as clinicians to treat, hassling with a variety of payers, health ministries around the world. And it's a population that we have neglected for decades in all of our clinical trials. And this is an attempt to remedy that. We know it's a heterogeneous population of patients. The diagnosis is difficult, and there are many of you in the audience who would challenge us to say that there is no such thing as seronegative MG. But hopefully we can dissuade you from at least part of that. So it represents somewhere between 15 and 20% of the populations we see. In an academic medical center, it's even larger because community neurologists want nothing to do with them, and they send them to the U, if you will. So the ADAPT-SERON study was designed to look at those individuals who had no detectable antibody by commercial assay. And the entry criteria are very similar, as you see in the left panel, to many of our clinical trials. AChR antibody negative, MGFA class mild, moderate, or severe with an ADL score of at least 5 and on stable therapy. In addition, these patients had to undergo review by an adjudication committee. Recordings of RepStim, single fiber EMG, clinical history, etc., were provided to this committee and then adjudicated whether they met the criteria. And people can argue about that, but this is a level of definement we wanted to try and establish a homogeneous population. The study was then in 2 parts. Part A, where patients received 4 intravenous doses of Efgart 10 milligrams per kilogram at weekly intervals and then observed for 5 weeks. At that point in time, they entered the first part of Part B, where they received 2 cycles, 4 weeks, off 4 weeks, and then retreated for 4 weeks, and then entered into the latter part of Part B, where their redosing was at the discretion of both the patient and the investigator. These are the baseline demographics, much similar to what we've been hearing about. There were some imbalances that I will show you here. There was a predominance of prior thymectomy in the active IMP arm. LRP4 was exclusive into the IMP arm by luck of the draw, and those experiencing prior nonsteroidal immune suppressants was overweighted in the active arm of Part A. These are the results. I call your attention to the column just to the left of the right-hand column where we see LS mean scores, and you can see the change relative to placebo in the overall population, that with MuSK antibody and that with triple seronegative antibodies. Don't be alarmed by the latter. When we look at the graph to the right, we see that all of this favors active IMP rather than placebo. And this is the ADL score across the entire population. And one sees that there is a placebo response, although much better than we saw in the ADAPT trial, where it was just off the wall. But there is clear improvement in the MG-ADL score. And then as we move into subsequent cycles in the open label portion, one sees further improvement in that ADL score, a cumulative effect, if you will. When we stratify these out by the subtypes, we see MuSK at the top, the triple seronegative at the bottom, and the LRP4 at the very bottom. We don't have placebo portion for the LRP4 population because they were all enrolled in the active IMP arm. But one sees that there is a delayed response that is more prominent as we continue to treat, and I want you to keep this in mind. Here again is the total population looking at the overall QMG change, and again one sees that with subsequent courses of therapy, further and continued improvement is noted in the QMG score that outweighs on the left panel what we saw with the placebo response. And again, stratifying by the non-AChR antibody type, MuSK at the top, triple seronegative in the middle, and LRP4 in the bottom, one sees again that there is a improvement in the first course, but a subsequent delay in additional improvement as we go on. Well tolerated, no new safety signals were seen. This is quite similar to what we've seen in the past. And as I've noticed in other of our trials, when we look at the incident rates per patient years, more prominent in the blinded phase, and as we go on with therapy, they seemingly become less prominent, but still much the same as we've seen with URI, nausea, headache, UTI, etc. The rates are very small and well within what we've seen in the past. So efgartigimod is well tolerated. We see no new safety signals. Treatment emergent adverse events were mild to moderate in their severity, and less than 10% in our overall population. We did have 3 deaths, 2 in Part A, 1 in the efgart group and 1 in the placebo group, not felt to be related to therapy, and then 1 in Part B, potentially related to efgartigimod, but we don't have additional data. We don't see an increase in infections relative to what we have noted in the past with the use of this compound, and none of these adverse events led to treatment discontinuation in either group, Part A or in Part B. And notably, no changes in seroalbumin, no changes in cholesterol are noted. So in summary, our primary endpoint in the change of MG-ADL was met, statistically significant at week 4 in these who are AChR antibody negative. In addition, there resulted in clinically meaningful improvement that went and extended beyond that. It was seen across all antibody subtypes, if you will, those with MuSK, those with LRP4, and those with triple seronegative. This study continues to demonstrate that pathogenic immunoglobulin may be an important driver across all patient subtypes, regardless of their antibody status, and well tolerated, and no safety signals are noted. And with that, I'll introduce Dr. George Lee, who will tell us about telitacicept. Thank you.
All right. Thank you, everybody. Thank you, MGFA, to let me to present this phase 3 clinical study, efficacy and safety of telitacicept with generalized myasthenia gravis patient. This is our disclosure. So we already know what is generalized myasthenia gravis. I will not spend time to present, but I just want to point one thing. In my personal opinion, in general population is they seems knew very little about myasthenia gravis. So my patient come to me, always ask me to rule out MS or AS. They never asked me to rule out myasthenia gravis. So since we have a lot of work to let general population aware this particular disease. What is telitacicept? So what this drug can do? This is not FcRn inhibitor or complement inhibitor. This drug have a dual mechanism. It block BAFF. It is B cell activating factor, which play a big role in upstream of B cell maturation and development. Also block another signal molecule, APRIL. This compound play a big role in the downstream of B cell differentiation to plasma cell. In turn, the final step is to reduce abnormal antibody production, also reduce the plasma cell maturation. So this is the study design. This design is very simple. It's have a screening phase of 4 weeks with a subject of 100 subject. Then will followed by part A, which is double-blind treatment period with 24 weeks. The placebo group and treatment group received 240 milligrams sub-Q weekly for 24 weeks. And then followed by open label extension study. The placebo group will getting the real drug. The drug group will continue the same treatment for another 24 weeks. So this is the endpoint. So we're look at MG-ADL score at week 24. Also look at ADL score and QMG score at a different period of time. Also looking for the patient which achieved the ADL score at least 3 points, and MG score achieved more than 5 points in the different times. So we're also checking for safety data. So this is the patient disposition. So we have total 114 subjects, which is equally divided to a placebo and treatment group. In the treatment group, only have 3 subjects discontinued, which is very small. So those two group have a matched age. It seems the female is a little bit more in the placebo group. The clinical severity is comparable. One thing I need to point out is only have 4 subjects with masked antibodies. Majority of people with HCHR antibodies. They all receive standard care for other treatment. So this is a result. So this is a ADL reduction over 48 weeks. The first half is placebo control. You can see there is significant differences in the treatment group. There is a 6.4 reduction compared to only 1.6 reduction of the placebo group. So the second half, it is showing the open label study. The placebo group received a real drug, which will mirror the first half of the treatment group. The treatment group will continue have additional decline of the ADL score. On the right, it was showing the percentage of patients with ADL score reduction of at least 3 points. There's a significant differences between the placebo and the treatment group. During the open labels duration, the placebo group quickly catch up, which is comparable to the treatment group. This one showing the similar data. This one is showing QMG reduction. Is showing a significant reduction in the first control placebo group, and during the open label period, the catch up very quickly after the placebo group received the real drug. The treatment group continue have additional reduction during the open label. This is the percentage of patients with QMG score at least more than 5 points. There is a big differences in the placebo control group. And so in the open label, which is showing a big quickly catch up. This one is showing the changes in RGG, RGA, and RGM, and CD19B cell count. So there is a significant reduction in all RGG, RGA, and RGM account during the placebo control group. During the open label group, they are comparable to the drug group. So the change in the B cell account there's some change, but it is not showing depletion of the B cell account. This is the safety data. There's no significant differences between the treatment group and the group with placebo, and then the treatment combined group. It is comparable, no significant differences. Also showing the whole 48 weeks, there are no significant differences. This is another safety data for infection. There is no significant differences between controlled and treatment group. Most of common infection is upper respiratory infection and UTIs. So conclusion, telitacicept showed sustained efficacy for up 48 weeks, which was well tolerated in GMG patient in this phase 3 trial from China. A global phase 3 multi-center randomized double-blind placebo-controlled trial with long-term open-label extension study is going on to evaluate efficacy and safety of telitacicept in patients worldwide. Okay, thanks for all the patients who is participating in the study, also to the investigator and site staff for the contribution. Thank you very much.
I still remember this conference where there was lots of chairs, but that hasn't been the case for, I think, the last decade. So it's my pleasure. Thank you for the MGFA to inviting me to talk about this presentation. I'm going to provide an update on the phase 2 part of the Kaiser 6, an open-label, single-arm, multi-center study of KYV-101, a fully human CD19 CAR-T therapy in generalized myasthenia gravis. I'm Srikanth Muppidi. I presented on behalf of my co-investigators. Here are my relevant disclosures. I don't have to go back into, I think Richard already talked about the role of importance of B cell, but the one thing that still stands, and I think we can still make a difference, is the degree of symptom control that we can offer to our patients. In spite of many of the novel therapies that are still available and being developed, there are still patients who have inadequate control. We can still aim to achieve MSC in most of the patients that we see. And with a lot of the novel therapies that have been approved are in pipeline, patients need to be on the novel therapies even if they have symptomatic improvement. And so there is a potential opportunity to think of therapies that you get a therapy and then you don't need to be on the therapy going forward. And then a lot of the novel therapies require chronic usage. And so this is where CAR-T has a potential that's different from all the therapies we talked about. If you haven't participated in a CAR-T therapy, or if you have not taken care of patients in your own neurology departments after having CAR-T therapy for oncology, essentially what happens is the process is slightly different from some of the novel therapies that were discussed or you might be using for myasthenia in your practice. We take the T cells from the patients, and then these are then sent off to a lab. CAR-T cells are produced. There's lots of quality control mechanisms that go through. Patient is brought back into the hospital, or sometimes even sort of talks about doing it as an outpatient, or given a small dose of lymphodepletion, and then they get their CAR-T therapies. KYV-101 has a unique CAR construct. It's a CD19. It has a CD28 co-stimulation, and fully humanized product. There have been about 100 patients that have been dosed across the board, and then has a very safe outcome so far in terms of cytokine release syndrome, or ICANS. And it has been shown in other publications that they have a deep and broad B cell depression and reduction in disease-causing B cells. There have been 3 publications. These are available, open, in Lancet and other journals, of GMG patients who've been treated on a compassionate basis, who've had minimal symptom state for a prolonged period of time from month 15 to month 24. I'll talk a little bit about this phase 2 data. So these are the straightforward inclusion criteria. Most of you are aware of it if you've participated in various MG trials. The one key aspect I want to highlight is the need for patients to have ongoing disease or failed 2 immunosuppressive therapies, or failed 1 immunosuppressive therapy and require chronic IV IgR plasma exchange. These patients get KYV-101 after lymphodepletion. It's a single one-time infusion. And then the primary endpoints were MG-ADL at week 24, obviously safety side of it in terms of adverse events. Secondary endpoints were QMG, MG composite, standard measures, antibody level changes, PK, PD, and then 18-month follow-up. Here are the baseline characteristics of the 6 patients. Key highlights are obviously all of them are antibody positive. Mean MG-ADL was 11, QMG was 17, fairly high-grade, moderate to severe disease burden. Same thing reflects in MGFA as well. MGFA class 3B, 4 of them, and MGFA class 4, 2 of the patients. The most important thing is at the bottom of the table, all of these patients had prior immunosuppressive therapy, resulting in still having a lot of symptom burden, including previous use of FcRn and complement therapies. And 3 of the 6 patients had prior rituximab therapy. All patients had robust CAR-T expansion and B cell depression after treatment. And this is the primary data that we wanted to share. On the left side, you'd see MG-ADL. Baseline MG-ADL is 11.2. The blue line sort of represents what's considered to be clinically meaningful reduction. And you will see there is a much more dramatic improvement in MG-ADL. One thing I do want to highlight is that this data cutoff is from October 3rd. And so only 3 patients have achieved the 24-week mark at the 6-month mark. And so you will see the minus 8.0 reduction is for those 3 patients compared to their baseline. That's for MG-ADL. Similar for QMG as well. So baseline QMG is 17.3. And then again, those 3 patients who achieved 6-month time period had a minus 7.7 reduction in QMG. The rest of the patients have not got to month 6, but obviously they'll get to soon. After single dose of KYV-101, patients achieved substantial and clinically meaningful reduction in MG outcome measures, as we measure 100% reduction, clinically meaningful reduction in ADL and QMG, 100% of the MG-ADL responders, which is a 3-point reduction. 2 out of the 3 have achieved MSE by month 6. 100% have achieved clinically meaningful response by MG composite. One important distinguishing feature compared to a lot of the novel therapies that have been approved or being tested is that when these patients are discharged after the CAR-T, they're essentially off most of their baseline immunosuppressive therapy. So 100% of these patients were free of their prior immunosuppressive therapy or high-dose prednisone defined as more than 10, or off their prior FCR and or complement therapies. And this is a key distinguishing feature compared to other therapies that are being either approved or being used. What about safety? There were no high-grade CRS or ICANS observed. Two patients had grade 2 CRS, and then which is cytokine release syndrome. 4 patients had grade 1 CRS. These were easily managed. There were 3 patients who had grade 3 or 4 neutropenia, but this was again managed very easily. 2 of them had a transient grade 3 or 4 neutropenia that corrected itself within 10 days. 1 patient had a grade 4 neutropenia, but fortunately there was no signs of infection, again improved with colony stimulating factor. So in conclusion, this data, I realized it's 6 patients, again shows that this fully human autologous CD19 CAR-T with a CD28 co-stimulation really does have a very safe profile in these 6 patients. We were able to show robust and rapid and sustained improvement in MG-ADL as well as QMG. All of the patients meet the responder status by MG-ADL, QMG, as well as MG composite. 2 out of the 3 patients have achieved MSC status. And then the important thing I wanted to again highlight is the fact that these patients are off their prior immunotherapy. This data, 6 patients and prior data, show this consistent, well-tolerated, and manageable safety profile. Some of this data led to sort of the process of coming up with a phase 3 trial, and this is a design for a phase 3 trial that's starting to enroll. Again, you'll see on the left side very similar inclusion criteria. Patients will have screening, washout, apheresis, and then they resume their standard of care. And we expect half the patients to go to KYV-101, and then the other half standard of care. And at the end of 6 months, patients can get their KYV-101. It has 2 co-primary endpoints of MG-ADL and QMG, and then we obviously will follow patients longitudinally. I would like to thank, obviously, my co-investigators. This study is sponsored by Kyverna, but I also want to make a note of all the patients who participated. It does require a lot more commitment on patients' side to participate in these trials. It does require a lot of organization by lots of different teams. And I want to put in a plug for a course that Dr. Ali Habib and I have. I think it's the first time, CAR-T in neuromuscular disorders, tomorrow at 8 a.m. Well, Dr. Habib is chairing it, so it'll be a fun session. So I look forward to seeing you all. Thank you so much. I think I get to introduce the indefatigable Dr. Vu.
Again, it's my privilege to present these data on behalf of my colleagues and co-authors. So I'll talk about the 12 months follow-up of a phase 2B randomized control trial testing the efficacy and safety of autologous B-cell BCMA messenger RNA CAR-T therapy. These are my disclosure and acknowledgement. So despite the fact that we made considerable advances in the treatment of MG in the last decade or so, there still remains unmet need for MG therapy that specifically target upstream, the pathogenic antibody-producing cells. So on the right side here, you can see that this is the diagram of the B cell maturation. And you can attack them based on the CD markers. And for us, for this study, we look at those cells that have the BCMA marker that toward the end of the cycles where these are blasts and long-lived plasma cells. These are the cells that actually produce antibodies. That's the mechanism of action of pathology in MG. So this study basically looked at selectively eliminated these cells and see how they affect the outcome clinically in patients with MG. So because it's mRNA based, it does not require lymphodepletion to allow the infused CAR T cells to proliferate. So as a result, we avoid the cytopenia and other long-term side effects associated with CAR T treatment. It can be administered in the outpatient basis, and like a drug, it's delivered at therapeutic level and does not rely on the T cell to proliferate inside the body. It is a transient cell modification, so it doesn't carry the risk of genomic integration. So similar to the conventional CAR T treatment, the patient undergo apheresis, where the cells are isolated, and then they undergo T cell expansion in the lab, and then RNA-based transfection to insert the receptor. Then they are cryopreserved, and then when the patient is ready, we bring them in and infuse these patients. So in the phase 2b study, they would be randomized 1-to-1 to receive either placebo or DCARTS-08, and we do the unblinding at month 3, and those who were on placebo get the actual cells, and the treatment is once weekly for 6 weeks. The infusion lasts about 25 minutes, and then we observe them for several hours. So the primary endpoint was to look at the change in composite score at month 3, and the threshold is 5 or more points improvement. We also look at other secondary endpoints, including MG-ADL and QMG, and of course, safety and tolerability. In this presentation, I will also look at 2 subgroup analysis. The study included AChR positive patient and RP4 patients, and also triple negative. We excluded MuSK antibodies. And so we look at the total population and compare them to the AChR positive antibodies patients as well. We also look, we saw something that's kind of interesting. So we sort of look at the prior exposure to the novel therapy of complement inhibitors or FcRn inhibitors. Here are the baseline characteristics. The numbers are fairly small, so we have 16 in the placebo group and 20 in the DCARTS group. As a result, there's some asymmetry. And the significant difference was 31% of the patients in the placebo group had a history of thymoma versus only 10% in the DCARTS-08. You see on the right side here, these patients are fairly treatment refractory in the sense that they've been through everything, including the newer agents. Patient was allowed to be on these, on the right lower panel there, these medications. They were allowed to be on complement inhibitors. They had to stop FcRn about a month prior to infusion. So here are the endpoints. So on the top left is the group overall populations with everybody included, and you can see that the placebo group achieved a 31% improvement by 5 points or more on the MGC. at month 3, and 67% of the patient in Descartes' group reached the same endpoint. And if you look at the ACHR population alone at the bottom left, you see that the placebo group is now reaching only 20% of them reaching the endpoint versus 64% in the ACHR positive group. This sort of guide the design of the currently ongoing phase 3, so that in this study only patients with ACHR positive antibodies would be involved. On the right side here is the your typical Christmas tree plot showing a different level of MGC score improvement, and at every level you see more patients in the Descartes 08 group than in placebo. In terms of secondary endpoints, MG-ADL and QMG, you see a significant placebo response at month 3, typical for most of our studies, but the patients who were treated with Descartes 08 have a more persistent outcome, so that by month 4, you had a 5.5 reduction, and that persists until month 12 of 4.8 point reduction. This was measured by the QMG scores. Again, placebo effect sort of stabilized by month 3. And then we look at patients who were treated, and you can see that they go from 4.8 improvement in QMG to 6-point improvement at month 12. At month 12, 83% maintained a clinically meaningful response. 33% of them was able to achieve MSE, and 55% was able to reduce background daily prednisone dose. So basically, we show that the response was robust and durable, and through month 12. We're looking at the different components of the MG-ADL, and you can see that all components contribute to the overall reductions. Maybe perhaps the breathing component seemed to be a little bit more robust. So as I mentioned before, we did a subgroup analysis looking at people who were treated with the novel therapy of complement and FcRn inhibitors. And those who were naive to these treatments seemed to have a better response. So they went from 5.2 reduction at month 3 to 6.6, and by month 12, 7-point improvement in MG-ADL. The same pattern you notice in QMG, going from 5-point improvement at month 3, and then down to 9.4 by month 12. And these patients, 100% of them were able to maintain a clinically meaningful response by month 12, and 57% of them was able to achieve MSE. In terms of adverse side effects, mostly grade 1 and 2. We have 2 patients that had a fever that persists more than what we expected. Most of these side effects usually seen about 4 hours after treatment, and usually last overnight, and by next morning they're usually back to baseline. There was no report of CRS or ICANS. There's no risk of infection that we saw. And after month 3, we did not see any additional AE. So basically, it's pretty well tolerated. So we also look at other markers. So for example, total B cells, antibody level, IgG, and so on. And common vaccine titers, we did not see any changes in those measures at month 3. So in conclusions, a single course of 6 weekly infusion of Descartes 08 administered in the outpatient setting resulted in robust and durable clinical responses at 1 year. Descartes 08 was fairly well tolerated. Most of the side effects was seen immediately the day of infusion, and by the next day they were gone. There was no CRS or ICANS or immunosuppression or cytopenia. So the phase 3 Aurora trial is currently enrolling, and thank you very much for your attention. So, Pushpa, welcome.
Almost good afternoon, and on behalf of my co-investigators, I'd like to thank the MGFA for the opportunity to present the top-line results for MAGIC, which is a phase 2 study of claseprubart in generalized myasthenia gravis. These are my disclosures. So what is claseprubart? Claseprubart targets the classical complement pathway through active C1s inhibition. So it inhibits the active form of C1s. And it's the first C1s inhibitor that has been evaluated in generalized myasthenia gravis. So what is it about C1s inhibition? Well, unlike C5 inhibition, which blocks all 3 complement pathways, and that happens downstream, obviously at the C5 level, claseprubart active C1s inhibition offers a more focused approach, and that has the potential to reduce the activity of upstream components, including the formation of C3a and C3b. It preserves the alternative and lectin pathways, and that both of these together, the prevention of C3a, C3b activation, as well as the preservation of the other pathways, may address disease pathology while reducing the risk of severe encapsulated bacterial infections that we worry about with C5 inhibition. MAGIC is a global phase 2 study of claseprubart in acetylcholine receptor antibody positive patients with generalized myasthenia gravis. The trial enrollment exceeded target, and 65 participants were enrolled. These were all adults with acetylcholine receptor antibody positive myasthenia gravis, and they were then randomized to one of 3 arms. You have here, after a loading dose, maybe not, yeah, after a loading dose of 15 milligrams per kilogram intravenously of claseprubart, participants were randomized into an arm with 300 milligrams subcutaneously every 2 weeks, loading dose of 20 milligrams per kilogram intravenously to 600 milligrams subcutaneously every two weeks, and the placebo arm. The randomized period was a 13-week period. The primary endpoint was obviously safety, since this is a phase 2 trial. So let's look at participant baseline characteristics here. Generally pretty good and equal across the 3 arms. I'd like to draw your attention to a couple of differences here. The median duration of the disease was lower in the claseprubart 300 milligrams arm, that's 3 years, compared to a little over 7.5 years in the other 2 groups. If you look at the mean QMG score at baseline, the placebo QMG score was slightly higher, 14.2 points compared to 12.2 in both the other groups. And similarly, if you look at the disease severity by MGFA class at screening, the placebo arm had a lower number of patients who were in the MGFA class 2, the milder class, compared to the claseprubart arms, and conversely had a higher proportion of patients in the class 3 and class 4A groups. Most other baseline characteristics, including standard of care therapies, were well balanced. In terms of the primary safety endpoints, generally well tolerated, about 50% of patients in the placebo group as compared to 62% and 68% in the claseprubart arms had some adverse event. Adverse events that were felt to be related and serious were really not many at all. There was just one in the placebo group. There were no discontinuations related to adverse events. Infections were noted in more patients in the placebo group than in either of the claseprubart arms, as you can see here. Again, related serious infections were really not seen, 1 in the placebo arm. Injection site reactions were a little less than 10% in both of the claseprubart arms. The claseprubart study exclusion criteria included excluded patients who had an ANA titer of greater than equal to or greater than 1 in 320. During the course of the randomized period, a few patients actually became newly positive for an ANA titer. That was one patient in the 300 milligram arm, 5.9%, and 36.4, 8 patients in the 600 milligram arm. However, what happened to these patients? At the 13-week analysis of the 8 patients here, 2 of them actually went back to becoming negative for ANA, and in 2 others, the ANA titers dropped, but they remained positive. What happened clinically to these people? Really, none of them developed clinical accompaniments of a positive ANA. Rash was not seen in any patients. 1 patient in the placebo group and 1 participant in the claseprubart 300 milligram arm developed arthralgias. So we see here comparable clinical safety profile to placebo with a pretty benign administration in terms of injection side effects, etc. No signal for infection and no symptoms really indicative of autoimmune activation. What about some efficacy measures? Here we have our usual change from baseline in the MG-ADL, normalized to 0 here. And you see that as early as 1 week, there's a separation between placebo and claseprubart, both arms. And at the 13-week analysis, a placebo-adjusted difference of 1.8 and 2.6 points in the ADL favoring the drug is noticed. Both of these were statistically significant. There was no difference between the 2 groups, however. What about QMG? Well, similarly, you see that same separation early on, and the change from baseline adjusted to placebo is about the same in both the dosing groups, 2.4 and 2.5 points. Both of them statistically significant, and of course, no difference between the 2 groups. How about our usual Christmas tree plot? Oftentimes easier to understand, I think, to get our heads around in terms of proportion of participants who respond. Over 60% of participants in the claseprubart 300 milligram arm, at 61% here, had a 5-point or greater reduction in the MG-ADL. Similarly, 62% in the 600 milligrams arm. Overall, you see this robust reduction in MG-ADL compared to placebo in both arms, really. For the QMG responder analysis, same thing, 60% of participants, 61% here, with a 5-point or greater change in the QMG score. And again, you see this sort of robust response here. In terms of minimal symptom expression, compared to 14% in placebo, the 300 milligram claseprubart arm participants had a 37% MSE achievement at the week 13, and that was statistically significant. So if you summarize these key efficacy measures, you will see that across key efficacy measures, we did see a very similar trend, response, placebo-adjusted response in the first 3 we've already spoken about. This is the MG composite mean change at baseline, statistically significant reduction in the 300 and the 600 milligram groups. QOL change, statistically significant in the 300 milligram group. So really, the 300 milligram Q2-week treatment arm achieved statistical significance versus placebo across all of these 5 efficacy measures. So what are my conclusions? Claseprubart was well tolerated and resulted in clinically meaningful and statistically significant improvements across key assessments, and has the potential really to deliver meaningful benefit to acetylcholine receptor antibody positive patients with generalized myasthenia gravis via infrequent self-administered subcutaneous injections, and a potential for reduced risk of encapsulated bacterial infections given how it acts. So let's talk a little bit about a sneak preview into the phase 3 trial and sort of our look at dosing for this trial. So some of this comes from the open label trial. So at this is the end of the randomized control period, and when participants crossed over into the open label. They did not receive a loading dose. They went straight to the 600 milligrams every 2-week dose. And about 4 weeks after that, you see this robust change in the MG-ADL, a 2.5 point drop, and that sort of stayed stable. The PK at this time with that 600 milligram dose was 65 micrograms per ml. And that PK is substantially lower than the observed steady state PK for the 300 milligram Q subcutaneous every 2-week dose, which was 100 to 120 micrograms per ml. So perhaps less is more, and all you need is that complement inhibition levels of less than 90%, which is what that achieves, may be sufficient. And therefore, the phase 3 trial will have a few differences. We will have a QMG screening criterion as well, and that is to be determined. And we will use the 300 milligram dose, but patients will be randomized to 3 arms again, looking at 300 milligrams every 2 weeks, as well as 300 milligrams subcutaneously every 4 weeks compared to placebo. I'd like to thank all our patients without whom this would not have been possible, and these are all our co-investigators, and this study was sponsored by Dianthus. Thank you very much. And our next speaker is Dr. Gwathmey. Hi, Kelly. I'm pulling up your presentation.
All right. Welcome, everyone. Thank you, Pushpa. That's a tough act to follow. It is a privilege to be here on behalf of Alexion and the PREVAIL investigators to present the efficacy and safety of subcutaneous self-administered gefurulimab in generalized myasthenia gravis, the top-line results from a phase 3 randomized double-blind placebo-controlled study. Here are my financial disclosures. All right, so everyone in this audience knows that C5 inhibitors are effective and well-tolerated treatments for adults with acetylcholine receptor antibody-positive generalized myasthenia gravis, which is a rare autoimmune neuromuscular disease characterized by fatigable muscle weakness. So gefurulimab is a novel dual-binding nanobody that blocks C5 activation and also binds to albumin. So it's very low molecular weight, so about 28 kilodaltons, compared to a conventional monoclonal antibody at about 150 kilodaltons. And it also has an extended half-life due to the albumin binding, which enables subcutaneous dosing at weekly intervals. So here we're about to present the top-line results from that phase 3 PREVAIL study, which was designed to evaluate the efficacy and safety of gefurulimab for treatment of adults with acetylcholine receptor antibody-positive myasthenia gravis. So here's our study design. So the screening period was 4 weeks or less, and patient eligibility, as mentioned, were adults with acetylcholine receptor antibody-positive generalized myasthenia gravis with an MGFA clinical classification of 2, 3, or 4, with an MG-ADL score of 5 or greater. They needed to be on a stable standard of care treatment and no requirement of previous treatment failure. So the subjects were randomized 1-to-1 to gefurulimab or placebo. 131 participants were randomized to gefurulimab and 129 to placebo, and the randomized controlled treatment period was 26 weeks. And this, again, is weekly subcutaneous self-administration of a weight-based study intervention. And then following that 26-week period, these subjects had the opportunity to roll over into an open label extension that was equal to or less than 202 weeks, followed by a safety follow-up. The primary endpoint was change from baseline in the MG-ADL total score at week 26, and the key secondary endpoint was the change from baseline in QMG total score at week 26. There were additional other endpoints, including the change from baseline in QMG total score at week 4, change from baseline in the MG composite total score at week 26, responder analyses at week 26, and safety. So looking at the patient disposition and baseline characteristics, 405 patients were assessed for eligibility, and 260 underwent randomization. As previously mentioned, 131 were assigned to receive gefurulimab, and 129 were assigned to receive placebo. 4 participants discontinued the trial in the gefurulimab arm and 7 in the placebo arm. That resulted in 127 participants completing the 26-week randomized controlled trial period on the gefurulimab arm and 122 in the placebo arm. And all participants beyond that entered into the open label extension period. So looking at the baseline characteristics, they were very evenly matched across the 2 arms. So not surprisingly, there was a slightly higher prevalence of women at just under around 60% in both groups. The age at first dose was 53 years in the gefurulimab arm and 52.7 in the placebo arm. I want to draw your attention to the fact that just under a third of the participants were Asian in both groups, and then just over 50% were white in both groups. The age at first clinical presentation of myasthenia gravis was 43 years in the gefurulimab arm and 43.3 in the placebo arm. The duration was a little bit higher in the gefurulimab arm at 9.2 years versus 8.2 years on the placebo arm. So the MG-ADL score was evenly matched at 9 points in both arms, and the QMG total score 14.9 in the gefurulimab arm and 14.7 in placebo. You'll see that the majority of patients were class 3, over 50% in both groups, and then followed by class 2 at just over a third in both groups. All right, so gefurulimab did show an early, sustained, and clinically meaningful treatment effect on MG-ADL total score. So it met its primary endpoint, least square mean change in MG-ADL total score at week 26. So in the gefurulimab arm, we saw an improvement of 4.2 points compared to placebo of 2.6 points for a treatment difference of 1.6 points, which was statistically significant. And I think extremely importantly, a clinically meaningful improvement in the ADL total score was observed as early as week 1 following the loading dose and was sustained through week 26. So looking at the QMG, the least square mean change in the QMG starting off at week 4, there was a 3.3 point improvement in the gefurulimab arm compared to a 1.5 point improvement in the placebo arm for a difference of 1.8 points, which again is statistically significant. Going out to week 26, the QMG score improved by 4.5 points for those treated with gefurulimab compared to 2.4 points for the placebo, again for a treatment difference of 2.1 points, statistically significant. So again, this is an early onset and sustained improvement as measured by the QMG total score. Looking at the incidence of adverse events between the 2 groups, so most treatment emergent adverse events observed were mild to moderate in severity, so a grade 1 or grade 2. And the most common treatment emergent adverse events for those treated with gefurulimab were injection site reactions at just under 10%, headache in just under 10%, and back pain in 7.6%. For the placebo arm, headache was actually more common at 12.4%, diarrhea was 8.5%, and upper respiratory tract infection in 7.8%. Very importantly, there were no meningococcal infections reported in either group. The percentage of participants with treatment emergent adverse events was similar between those who received gefurulimab and placebo. So in conclusion, in one of the largest phase 3 studies in patients with acetylcholine receptor antibody positive generalized myasthenia gravis, PREVAIL met all primary and secondary endpoints. Gefurulimab is a novel, dual-binding nanobody self-administered with a pre-filled syringe via subcutaneous weekly injections, and it provided early and sustained efficacy in adults with acetylcholine receptor antibody positive generalized myasthenia gravis, based both off of patient and clinician-reported outcome measures. The meaningful improvements were observed early as the first post-baseline MG-ADL total score assessment at week 1 and QMG total score assessment at week 4, and these improvements were sustained for the duration of the 26 weeks. Gefurulimab was well tolerated and has a safety profile comparable to other terminal complement inhibitors such as eculizumab and ravulizumab. There were no new safety concerns identified and no meningococcal infections were observed. So in summary, gefurulimab demonstrated a favorable benefit-risk profile based on these clinical benefits and the advantage of the self-administered subcutaneous weekly dosing, gefurulimab may offer patients with acetylcholine receptor antibody-positive generalized myasthenia gravis a convenient and effective treatment option. And with that, we would like to thank the patients who participate in this study, their families, and the study investigator teams. And you will see the support here as well as a QR code to access this presentation. Thank you for your attention.
All right, thank you to our speakers. We'd ask you to come up to the front of the room so we can take some questions. Great. We'd like to open it up for questions. All right, Mike, go ahead.
Hello. So I have a question for the two pediatric neurologists because we don't hear from you enough. So I'm curious, in both studies, what was the thinking around thymectomy for the juvenile MG patients? Was it delayed for participation in the studies? Did you allow it? And how are you envisioning it in the treatment paradigm as you think about these two agents?
Yeah, sure. I mean, just like the adult MG, we try and get thymectomy in our pediatric patients within the first year of diagnosis in any patient that's acetylcholine receptor positive. It was somewhat of an exclusion criteria depending on when they had gotten the thymectomy. I believe it was 6 months prior. They had to be 6 months prior to the procedure in order to enroll in the study. The patients that we had enrolled in our site had already had the thymectomy well before enrollment, and so they were able to enroll into the study.
Yeah, I mean, I think same thing. In standard of care is still something that we all go by, and these are patients who are not doing well on standard of care, and we all, I think, are realizing that the earlier we do thymectomy for our patients, the better the outcome and a higher rate of remission. So we allowed that. Again, like they were stable for several months before.
Question for Dr. Muppidi. Hypogammaglobulinemia, is there ever a concern for those who received CAR-T?
So in these 6 patients, no, that hasn't been a big issue. But I think some of that, maybe we can talk tomorrow in the session. I think there is changes in the level of IgG reduction based on if you target BCMA versus CD19, so there's a variable response here.
Good. Question for Dr. Vu. If nipocalimab does not change albumin, why does it cause leg edema?
That's an excellent question. We actually don't know. So yeah, like you said, there's a number of patients in the trial that have edema as part of this observation. But that got, for most of these patients, they resolve over time. But there's no explanation for it, as far as I know.
Can I ask one more question? Dr. Nowak, I need you to speculate. You are the PIs for 2 B-cell depletion therapy. One is Minitrol, the other is the beta MG, which generate very different results. Why is that?
That's an excellent question. I didn't speak to BeatMG. So for the audience that is not familiar with BeatMG, that was a phase 2 clinical trial that looked at rituximab in patients with acetylcholine receptor antibody-positive disease, primarily looking at safety. The study design was a futility, looking at ability to reduce steroid dose. So we can't conclude based on the BeatMG study results that anti-CD20 rituximab is not efficacious. The response and observations that we had in that study did not lead to a go decision for phase 3, which actually led to us considering, well, are we really targeting the antibody secreting cells that are driving autoimmune myasthenia gravis? So been very nice talks talking about CAR T, but we did not believe that rituximab in all patients, despite case series and anecdotal reports that it is beneficial for patients, that it resulted in a robust, reliable response in all patients. There's the Rhinomax trial and the BeatMG, which lead to diverging conclusions. But we do believe with anti-CD19 directed B-cell depletion that we're actually more reliably targeting the antibody secreting cells in a way that results in clinical benefit as demonstrated by the placebo-controlled inebilizumab phase 3 clinical trial. So I think that the overarching sort of conclusion would be that, yes, B cells are important, and targeting the appropriate B cells are critical to result in clinical benefit for our patients, which can be quite heterogeneous, I think, especially in the acetylcholine receptor antibody population. So I'll just cut my response there.
I wonder if the patient in the main trial, the disease duration is much shorter than the beta-MG participants.
We looked at that, not especially so, and we also have initiated some additional subgroup analysis looking at disease duration. Those data are forthcoming, but not presented here at the conference.
Thank you.
Great session. Thank you to everybody. Question for Dr. Howard. So 2 things about the seronegative study. One is, in the adjudication committee, what measures were taken to exclude genetic myasthenias or related things like OPMD in people who are electrophysiology positive? And then second question is there a plan to look at cell-based assay, so live cell-based assay, antibody positives and response in the commercial seronegatives?
Genetics were not tested. We talked about it. I favored it, but the group said no. So that's always a risk. But the decision was made by 2 individuals. If they were divergent, a 3rd individual. And so it related to, the various clinical pictures, physiological pictures that we typically use. Yes, it's a limitation, but it's an inherent part of the study. Whether or not there are samples that will be looked at under a cell-based system, I can't answer that. We'd have to go back to the sponsor.
Thank you.
Yeah, Anna.
I think that's a really important question, but we really also assess the treatment response on immunosuppressive treatment as well as in addition to that. So I think that also, in addition to really looking through the neurophysiology and all the clinical picture, gave that very strong evidence of seronegative MG.
Right.
Yeah.
And Anna was part of the adjudication committee.
Yeah, the problem is steroids themselves have so many effects, including actually changing the density of AChR. So, response to steroids alone is questionable in that.
Hi, my question is for Dr. Vu for the nipocalimab study. It looks like, so on the section, and it's hard without a slide, on the section talking about weaning prednisone, going out to week 60, it looked like the curves for the patients who were on placebo and then switched to nipocalimab versus people who had been on nipocalimab from the start separated out. Is that a real effect, or, and any thoughts on that?
Okay. So the question whether the 2 groups who be treated differently in the placebo-controlled period diverge. I think they are a little bit different by maybe a point. I don't think the difference was statistically significant. So I think the number is pretty small too, so that may be a reason. The good thing is that the open label is still ongoing, and hopefully by next year we'll have some more data.
Okay, thank you.
I have a question for Chip. So for the seronegative study, it seemed to me that the placebo effect was greater with additional cycles. Was that what you showed?
No, I mean, the placebo was only in cycle 1, and then everyone else transitioned to active drug.
After drug,
And
okay.
so the graphs, what you were seeing were those who were FGART, and then placebo FGART.
I see. Was it comparable to ADAPT?
Yes.
Thanks.
Any further questions? Yes.
I wasn't sure if we are allowed to ask questions. I'll be quick. This is a question for Dr. Lee. You know, what's impressive about the data was that compared to lots of the phase 3 data that's been published, there's very little placebo effect in your presentation. And is this something that we are not doing right or something you're doing much better? Maybe you set the bar better?
There is some placebo effect.
But it's a lot less than what's traditionally seen. That's what I was curious about.
I'm not sure. So.
Thank you. Great presentations. This question is for pediatric neurologists John and Abigail. I'm a pediatric neurologist myself, and I do see myasthenia. And you know, as the menu of options for these treatments are growing, I wanted to understand, when do you bring in these? Like, is it something to rescue patients when they are getting on to, say, plasma exchange on a monthly basis, or they're not responding to IVIG? So going back to, what is your inclusion? And this question is for many of you, as you notice that your inclusion criteria, except Dr. Sri's, where you had mentioned 2 refractory, you know, that makes more sense. But for others, I'm not very clear when will these drugs get into place. So any suggestion for clinicians who are in practice as these gets more FDA approved, when do you start putting them in, starting discussing, should we go for FCR receptor, should we go for rituximab? And I understand those on plasma exchange, I would love to get them off the plasma exchange. So can these drugs rescue those patients? Has there been any cases in your studies where you were able to get those patients out of plasma exchange by using these drugs?
So great question, and I think, you know, for a long time we didn't have a lot of drugs that were approved for pediatric myasthenia, so a lot of insurance companies would kind of deny us. In fact, like I remember the first time I wanted to put someone on eculizumab, and it was approved for pediatrics, and the insurance company said, have you tried rituximab yet? So it was kind of interesting to hear insurance companies telling me what order I should put the drugs in. But I think that the more we get these drugs approved, the more we can kind of figure out what is the best way to do this. And I think the problem is that the patients needed to be stable and couldn't be on plasma exchange to be able to get these drugs, because they would just get rid of the effect of the drug. So that this is not, we haven't seen that in these patients. It would be nice if we can get these patients off. We've had patients who've been on a lot of plasma exchange that we've started some of these other agents to be able to wean them off plasma exchange. So I think it's a possibility. And it is nice to have some new tools to be able to try to do that for our patients.
Yeah, I think it's tough because our approach is so different from the adult world in terms of like what medications we're comfortable starting and, you know, what severity of disease we're comfortable dealing with. You know, I tend to not start patients on steroids long term, so they'll be on a very short course of steroids, and then I'll try and get them off pretty quickly because we know that changes height velocity in children, bone density, all these things that impact quality of life. We tend to turn to IVIG pretty early on and avoid some of the oral medications, just again because of the side effect profile that we see in children. So my practice at least has been to try and stabilize them initially on steroids, Mestinon, and IVIG. If they don't seem to be responding adequately to those medications, then I have been going towards the FcRn receptor medications, so starting kids who are 12 and up on nipocalimab pretty early on, with the idea of also adding on something like rituximab for more long-term treatment management. And then with efgartigimod not yet approved for pediatric patients, we worked many years ago to help a child get on efgartigimod through an IND and have seen really good success with those medications in children.
Hi, this is a question for Pushpa. So with the proximal C1 pathway and the potentially reduced chance of meningococcal infection, do you think that this will change the guideline, as it is a constantly changing, and we are chasing it in so many different ways currently? So do you think that it will change how we vaccinate these patients going forward?
The answer is I do not know, and the answer is it depends. But there is one drug approved of the same class, C1s inhibitor, for cold agglutinin disease. And so what the way that has been handled there's no black box warning. There is still a requirement for vaccination. So sort of a lower level, concern, if you will, about it. But I don't know, and I may be completely wrong, but I don't know that it will completely take away the requirement for vaccines. But I think.
And for this study, what was the schedule?
They all received the usual schedule that we had in the earlier studies, 2 weeks.
2 weeks.
Yeah.